all here for trauma rounds, bright and early. Dr. Haegert, who's one of our trauma team leaders but also an emergency room physician, is going to present to us on some interesting cases that we've had over the past several months, is it,
Yeah, well,
Joe? Over the past year. And they're all based on a theme, which is kind of cool. And the theme today is going to be urology. And hence we've got Dr. Yang here, who's been kind enough to drag himself out early this morning. Exactly. Thank you, Dr. Yang. And and none of us can top being in the mountains with Dr. Haegert. So he just got back from Nepal, so he's here to present to us today. Want to take it away?
Sure. Thanks, guys.
Oh, and
I'm sorry it didn't work out province-wide. You know, I don't know if province would hear us. They probably can't. It's the technology is disaster here. So just a couple pictures of Nepal. I was there for the last 3 weeks. It was just a great trip. And so we'll start. I've just got some cases. I was hoping to make it sort of discussion-oriented and a case-based. So if anybody has a comment, especially Brian, if you've got some comments to make, just go for it. Because some of the cases, one of the cases is yours anyways, or you're involved in. So the first case, 34-year-old male brick manufacturer, or worker laborer, I guess, was crushed. Heavy machinery hit a table and sort of dragged him across the room about 10 feet and pinned him against the wall with a very high force. So pre-hospital, his vital signs were abnormal in that he had a sinus tachycardia, but he was awake and alert. So that did not necessitate a pre-hospital trauma activation. So he wasn't shocked, didn't have a decreased level of consciousness. And we're just changing our trauma activation criteria now to some 5 sort of physiological criteria. So in the ED, he was shocky. Pressure was a little soft. Pulse was very fast, which, as you guys know, in trauma is shock until proven otherwise. He had clinically had an unstable pelvis, no respiratory distress. GCS is starting to drop a little bit. He wasn't moving his legs at all, and his fast was positive. So I hope I don't mind if I'm going to pick on somebody. Gunnar, do you mind if I pick on you? So what do you do now? You got this guy, he's in shock. He's got some peripheral IVs. He's got, say, 1 peripheral IV. He's awake, but he's a little drowsy. He's pretty shocky. He's got this unstable pelvis. He's not moving his legs. Fast is positive.
You want to get some volume, so some crystalloid, get some blood ordered fairly quickly. It might think about binding his pelvis, but the fact that he's not moving his legs is worrisome. So that there's the movement that occurs with binding the pelvis, there's the potential for causing some harm.
So that's a good point, but you probably still bind it anyways.
But you'd probably bind it.
Because the shock would override the neurological concerns there.
And get some blood for him, and he probably deserves a CT fairly quickly and alert the interventional radiologists, because if he's got an unstable pelvis, then he's possibly to benefit from some interventional radiology. And then you need to assess his perineum.
Exactly. So there's a lot of stuff you need to do. So probably don't need to intubate him right away, but pretty soon you're going to have to intubate him. Like that's gonna happen. And then rapid transfusion protocol, bind the pelvis. And often with these sort of things, you can see how they do over the next like 20 minutes or so, because it may be he stabilizes. Go ahead, Bert.
He doesn't have a head injury, so permissive hypotension is not something that would be unusual in this patient. And I wouldn't be trying to bump up his blood pressure with crystalloid. I'd rather do a rapid metabolic profile, see what his basic test is, and start a massive transfusion protocol. He might be a candidate for all of those things as well.
Yeah, and also you might, the transexamine acid, you can think about that as well.
Yeah, that should be on our massive transfusion protocol. Yeah, exactly.
So I just thought I'd throw up this. This is our proposed new pre-hospital trauma activation. So shock, intubated or respiratory compromise, low GCS, less than 8, penetrating head, neck, or torso trauma, and major pediatric trauma. So we've kind of gone away a bit from mechanism and gone to physiological criteria here.
well, we haven't had mechanism for a while, but we don't have auto launch on there anymore, so that's not automatic activation. So if they come in a helicopter, if they meet those shock physiologic criteria, then those are an activation. And it's important to bring us in for a bunch of reasons, and you'll see.
So you can see here.
The one's still a little bit fuzzy though, isn't it? But,
What's that?
the pediatric trauma is still a bit fuzzy. But
Yeah, that's fuzzy. It's deliberately fuzzy. I think with pediatric trauma, it's all hands on deck sometimes. So, yeah, you're right.
And also at your discretion. I mean, a lot of the emerge docs we hear, if you really want us there and you want help, just phone. Nobody will say no. It's important that you call at your discretion as well.
So he's, you can see he's intubated. This is his chest X-ray, and here is the pelvis X-ray. So you can see it's a open book type pelvic fracture. He's got a Foley catheter in, so I wasn't there, but I guess the rectal was done, and prostate was thought to be okay, and there was no boggy hematoma or blood at the urethral meatus. So they put a Foley in, and he's bound. All right, so his pelvis is wrapped. He's intubated. I think Jonathan Thierry put a subclavian line in. Massive transfusion protocol. Trauma was activated because now he's shocky. Foley was placed. So now his pressures.
Joe, was he ever moving his legs before he got intubated?
There was a bit of movement in the left leg, but not much, and both legs were not moving much at all. So now he's, yeah, not much movement of his lower extremities. Upper extremities is moving fine. So 10 units of blood, some FFP, pressure's up now. So BJ, what now? Now that you...
Comfortable, they've got the pressure up, but he's only had FFP. I would hope that we've got some blood work back, because what about platelets and cryo and...
It actually wasn't too bad. His hemoglobin came back about mid-90s or so. Platelets are okay. He wasn't that acidotic. His bicarb was running around 18 or 19. So I forget who was running this, but they did a good job resuscitating him. So
after we go to the scanner?
Go to the scanner, exactly. That's probably fair enough. Fair enough. And obviously call all the other specialties involved here. I mean, he's got a positive FAST, you'd probably call Gen Surge, you'd call Urology, or we don't know yet, but we'd call Ortho for sure. So, okay, so I got a couple of scans here. And I'll just take a look at that. I'll point out a few things here. There's a few obvious things that, well, maybe Tom, have you seen this scan before? Tom, are you able to comment on this a little bit? This scan? That's a nasty thing to say.
I think he's got a
Yeah, the psoas is all obliterated, and you can't see it well, and it looks like a retroperitoneal hematoma here. I would buy that. There's probably some down in the pelvis as well, down here on the right side.
One of his kidneys is not.
Okay, so he's got looks like a non-perfusing left kidney. So that's like a grade 5 kidney injury. Exactly. Plus there's a little, so that's probably the biggest thing. Plus he's got a bit of fluid. You can see there's some fluid here, which is intraperitoneal fluid. It was described by the radiologist as moderate intraperitoneal fluid, goes right around the liver. And if you look at his right kidney, he's got he's got perinephric fluid right here as well, which is a bit unusual. He's broken most of his transverse processes. That's one transverse process, which is sitting out here. You can see his SI joint's a little wide right there. Let's see if I got some more images to you. His mesentery, this is some of the mesentery here. There's hematoma in the mesentery. You can see more of the blood in or fluid in the belly here. You can see this is a well-perfused bowel. Some of the bowel is a bit borderline, like down here. So just bear that in mind. It wasn't commented on by the radiologist, but just keep in mind of that. And here's another look at the bowel. Whoops, it is. See, there's a little bit of, so good bowel has a good rim, like that, and less good bowel, the rim is, well, there's less of a delineation. So that wasn't commented on, and you can see, of course, this kidney here is dead, or at least infarcted, and this kidney here, which is perfused, but there's fluid around it. So the CT report was a grade 5 left kidney injury, moderate hemoperitoneum, mesenteric hemorrhage, open book pelvic fracture, I think I already said the hemoperitoneum, retroperitoneal bleeding, multiple lumbar transverse process fractures, and no solid organ injury. So, Rarity, what would you do now at this point in time? Or Peter?
I just wanted to, what about his spine? Was there a comment on this?
No significant spinal fracture. Now, there actually was a little bit of a compression fracture, but no unstable spinal fracture.
So nothing to suggest.
So it turned out it was a lumbosacral plexus injury.
Oh, okay.
From his, he was squished so hard and his pelvis was opened up so much that there was probably a shear and a tear or a squish of his lumbosacral plexus nerves, and he just, like a rare cause of paraplegia, but he's essentially paraplegic not from spine, but from bilateral lumbosacral plexus injuries, which actually long-term, that's his main issue too. So Rarity, what do you do now? You've seen all those injuries, you've got that stuff, and so what are you thinking here?
So there's a couple things. So I kind of know a little bit about this, but my concern right now is with respect to the kidney and the entire the renal system and into the bladder. So I'd need to reassure myself that there is no bladder injury. Plus, I'd also want to know, have we done any delayed scans on the table if he was unstable? Just do a plain film in the emerge on the trauma bay. So you do a plain abdominal film and you can see if there's any flow going through the ureter on the right side, because that's his only kidney that's currently functioning. Grade 5 renal injuries, you can go in and take out the kidney if the patient's unstable. I wouldn't necessarily do it right at that moment. He definitely needs his pelvis stabilized. I'd look for blushes and see if he needs angio there. And then with respect to the hemoperitoneum can occur for a couple of reasons. So a FAST is often positive when you have a pelvic smash because of the retroperitoneal hematoma. But in the absence of that, if he just had free fluid in his abdominal cavity without a solid organ injury, I'd be worried about a hollow viscous injury. But in this case, because he's got the retroperitoneal hematoma, I would think about it, but I wouldn't necessarily operate on him until I had all my ducks in a row, like with respect to knowing what ortho is going to do, knowing what urology thinks about the kidney, and depending on how stable or unstable he is. So if he becomes unstable, he goes to the operating room after we go to IR, or we could go to, does everybody know about the multipurpose suite? Because the multipurpose suite, we could probably get an angio in OR12, then followed by a laparotomy at the same time to control any intra-abdominal bleeding or hemorrhage.
So, yeah, there's a couple of points there. So, Brian.
Yeah. Can you go back to the CT scan for a second?
Yeah, sure.
First coronal view.
That one.
That's one. Yeah. So, I wasn't the urologist involved when this patient first came in. It often happens. It comes in on Thursday evening, and a new guy takes over Friday. You get a call at 7 saying, "Brian, how are you? By the way, my trauma came in last night." But there are at least 3 indications for delayed scan. This is called the nephropathic phase of a CT scan, where you inject the contrast, where you first do a non-contrast scan of the body. You inject the contrast between 1 to 2 minutes. You do a second scan, and that's when the kidneys light up like this. So this is called the nephropathic phase. And then the delayed phase that Rarity was talking about is 10 minutes after the injection of the contrast. You repeat the CT scan, and the contrast should be excreted into the ureter at that point. So unfortunately, the radiologist didn't recognize that this patient should have a delayed phase scan in this case. And there are 3 indications in this patient in particular to get a delayed scan. And first is mechanism of injury. A huge deceleration injury in this patient should necessitate a delayed CT scan. 2 is that there's a medial something, doesn't matter if it's a hematoma, a urine leak, something's coming medially off
Right
the
here.
right kidney.
You're right near the renal pelvis.
Exactly. That's the
There.
second indication for delayed scan. And third is if you have low T spine, upper L spine, transverse process fracture, likelihood this patient may have a renal injury or a collecting system injury. So that is the third indication for delayed CT scan in this patient.
Yeah, so that's a huge point actually, because it's something that I actually wasn't aware of. And so I think delayed images are something that I kind of wanted to emphasize on this case, is that if you think at all, there could be a renal pelvis injury, encourage the radiologist to do the delayed scan, or you could do just a KUB X-ray back in the trauma suite is the other thing you could do.
Our problem is these patients are often unstable, so they're not good candidates for hanging out in the CT scanner for an extra 10 minutes.
So in that case, then they need a one-shot IVP in the trauma bay. So inject contrast, 10 minutes later, one-shot IVP.
So when you come back from scanner, you can just do a plain film. You can usually time it because we're out of scanner by 10 minutes back in the trauma bay, and I've done that a few times now after, with my great experiences of missing ureteric injuries. Don't ask me how I know. And it's been very helpful. And it also gets, kind of makes the patient a lot safer with respect to delaying them in the scan.
Would you get more contrast in the trauma bay then? Like
I
as
haven't
Brian suggested?
needed to.
Would you, Brian?
You probably don't need to. I mean, it all depends on the timing. If it's within that 10 minute, and you can use the contrast they gave. But if it's past the 10 minute, you have to give another bolus of contrast, wait 10 minutes, and take the X-ray down.
So what you want to see is you want to see some contrast going down the ureter. That's all. You're trying to make sure the ureters are okay. Barry?
So part of the problem is, I mean, if the patient's unstable, you're going to be over with them, and you may be able to pick this off. But if they're not as unstable, or you've got other people that are injured, you may not be in the scanner, and they're back before the late image can get done. And a lot of the traumas are in the evenings, and the radiologists are reading from home, and it's long after the patients come back from the scanner.
Yeah, so that's probably not good.
But that's what mechanism's helpful, right? So if you know they're crushed, then you just do it. But the other thing is you can always give them another dose if they're stable. I mean,
And
obviously if they're stable.
this was 3 in the afternoon too, so this wasn't in the middle of the night. So that's a really important point, I think, to emphasize in the case here.
The other comment about the completely devascularized left kidney, nowadays if the patient's stable, it doesn't look like it's bleeding, it's completely devascularized. If they have two functioning kidneys, the chances of saving that kidney is extremely low, especially as time goes on. So that's called warm ischemia, when you completely cut the blood supply off of the kidney, and all the nurses know during my lap partial nephrectomy, a warm ischemia time of over 30 minutes, the kidney starts to die. So usually it's been well over 30 minutes by the time patient gets to your trauma bay. Operating on that kidney, try to revascularize it is probably, in a guy with 2 functioning kidneys, is probably not ideal. And in most cases like this, we just leave the kidney. In the future, we have to watch for hypertension, and in the future, if he develops hypertension, we can do a delayed laparoscopic nephrectomy in the future.
Yeah, so the literature says that the chance of revascularizing the kidney is about 0%. It's really, really bad. Okay, the other point I wanted to emphasize is that this hemoperitoneum is that you got a hemoperitoneum, but you don't have a cause. If you got a solid organ injury like a liver and a spleen, then you got a cause. But if you don't have a cause, then just like what already says, think bowel. So you pretty much know this patient's going to be heading to the OR. So you're worried. Your index of suspicion is higher. So okay, so that's what we've got. So what happens now? So patient goes to the ICU. Intermittently hypotensive, requiring fairly large amounts of blood, placed on a norepinephrine drip, and is anuric. Okay, so we already know now what. Now what? Well, now it's up there in the ICU. So surgeon hasn't taken the patient to the OR. Patient's anuric, not explained why. So repeat CT scan. So here's the repeat CT scan here. And I'll just go through some of the findings. It's kind of interesting. So there's much more hemoperitoneum here. There's the dead kidney, but now you got this contrast leak right here. You can see it right there. So what's happened is that the proximal ureter has been torn off the right kidney as well. So you have a left grade 5 kidney and you have a right grade 5 kidney too, because that's also considered a grade 5 when the ureter is ripped off of there. So now the patient goes to the OR, and that's when Brian gets involved. So Brian, can you tell us what happened in the OR?
So I got a call. It was 24 hours after this happened, and they said this patient hasn't put out any urine for the last 24 hours, and we got the CT scan, and it shows that he's leaking urine into his abdomen. So I had a chat with I think it was Rob. Was it Nason or Rob?
It was Nason.
It was Nason, right? And he says, I'm taking the patient to the OR. What do you have to do? So we took him to the OR. I took out that left kidney just because we were in there already, and so we decreased the chance of hypertension at that point. Then I took a look at the right side, mobilized the bowel over, and the ureter was completely torn off at the UPJ, and that's the most common place where ureters tear, because it's tethered to the retroperitoneum at that point. So the sheer energy, this guy got chucked between two brick-making machines or something like that, and the sheer energy just tore that ureter right off, and it had to be tracked all the way down into the pelvis. So there was a good 30 centimeters between the kidney and the ureter. We're lucky enough that I was able to extend that ureter, pull it up. I mobilized the kidney and dropped it down about 5 to 8 centimeters, and we were able to just get the tips of the ureters to touch. And I could tell at that point that as the ureter shears off, it destroys its entire vascular supply, and it didn't look very healthy at all. But what Nason did was he had a whole bunch of these skip lesions in his bowel, so all Nason did was did a bunch of resections, and that bowel closed all over the place. So this guy actually had a whole bunch of segments of bowel just sitting around and stapled across. And so he said, okay, take this guy back in 24 hours or 48 hours anyways. So what I did was I put a stent down the ureter into the bladder, and then I put the stent up in the kidney, and I did an anastomosis with absorbable 5-0 suture, and hoping that this will hold. Now the biggest thing in ureteric repairs is that you want a watertight, stented, tension-free anastomosis, and this was not watertight. It was stented, and it certainly wasn't tension-free. So I was hoping that it would stick. So what I ended up doing was I told you I mobilized the kidney down. I sewed the kidney to the retroperitoneum, mobilized the renal pelvis down as far as possible, and I sewed the two ends of the ureter to the psoas muscle to try to make it tension-free. But 24 hours later, we had a drain inside the abdomen, and he was leaking urine in the abdomen. So Nason called me and said, I'm taking this guy back to put his bowel back together. Humpty Dumpty. And so I went back and I put a second layer into the anastomosis, and the anastomosis looked intact, just the back had necrosed off of the ureter. And so I redid the anastomosis, and it helped. It helped.
Great job. Good job.
Kind of neat.
So here's some. So go back here. So here's some more pictures here, and it's probably not clear to some people, but let's see if I can get my little mouse here. But there's some dead gut in here, like some of this gut, like that would be gut. You can see a nice good rim here. Over here, not so much. And anyways, there was multiple that you can see on the CT scans. There was multiple loops of dead gut as well. So probably it was infarcted gut, probably from all that mesenteric tearing, and probably it was avascular. So pretty complex case. There's some more dead gut with some pneumatosis in it, right there. So 145 centimeters of gut was resected after those 2 ORs, and we heard already about the urological stuff. Now, interestingly, the spleen was also lacerated, and it was not seen on the CT scan. So that's another important teaching point, is that just because you don't see something on the CT scan, it can still be injured. And I just had a case I discharged, I don't know, a month ago or something, 3 weeks ago, who had a normal CT scan abdomen, who had an emergency splenectomy 10 days after discharge. So it was missed on CT scan. So it's important to realize that with spleen injuries, you don't necessarily, you can miss them. CT's not all seeing. And also the left hemidiaphragm diaphragm was ruptured, and that was not seen on CT scan as well, but it was picked up intraoperatively, and it was also repaired. So Just another thing, bowel can be missed on CT. You know, you can get proximal ureter injuries missed on CT, spleens. So it's something you gotta look at it really carefully, and you gotta follow patients clinically. Okay, so lessons learned. These are a few thoughts. I mean, we talked about this, but maybe it's worthwhile re-emphasizing it. If there's hemoperitoneum but no solid organ injury, consider bowel. The delayed views, that was kind of a new concept to me, but get delayed views on the CT or in the trauma room if there's fluid near the pelvis, or the other things that Brian was saying too. Like what you said, multiple transverse process fractures and mechanism. Yeah. And my personal bias is if you have a really bad open book pelvic fracture like this, even if they don't have a blood at the urethral meatus or scrotal hematoma, I usually do urethograms on all these just in case, because they usually have a tear. It's about 50% they're torn in males, so I would do a urethrogram in this case, but it worked well, but fortunately there was no urethral injury. And CT scan can miss things. So this is the grading system here for kidney trauma. People probably know it, but it's worthwhile going through. So grade 1 is basically normal imaging, so hematuria, normal imaging. If you have normal imaging and hematuria, gross hematuria, think bladder rupture. So that's going to be the next topic, but just if you think of that, think about a bladder rupture and do a cystogram of some sort, either a CT cystogram or something else. Grade 2 would be a cortical laceration less than 1 centimeter, or a perinephric hematoma, but not involving the collecting system. Grade 3 is a deeper laceration, but still not involving the collecting system. Grade 4 goes down into the collecting system, or there's segmental infarcts, or there's an expanding hematoma that's compressing the kidney. And then grade 5 is one of 3 things. It could be a shattered kidney, or a devascularized kidney, or a tear of the proximal ureter off the kidney. So 3 things that can make a grade 5. So this guy had bilateral grade 5s. Kind of a interesting case. Any other final comments on that case?
A couple of things is that you guys, the emerge guys and the trauma guys, you guys are really good at getting cystograms, which I think is excellent, because any kind of, these are mechanisms of injury. Usually you get pelvic trauma, things like that. If you're going to do a urethrogram, you should probably do a cystogram, and a proper cystogram requires 300 cc's retrograde into the bladder. So I know a lot of other places they should clamp the Foley, do a delayed phase on the CT scan, and they think that's a cystogram. It's not good enough, and this is too many bladder injuries. The second point is that the delayed phase sometimes shows what's called a UPJ laceration. Okay, so that means the ureter gets opacified, but there's a leak. Okay, this is a rare thing, but it happened about 4 weeks ago in a young 15-year-old kid who was playing soccer and had a collision with the goalie, and he had a UPJ laceration, so it didn't tear right off. It got lacerated. Those can be treated conservatively by watching them, even though there was a bit of a urine leak. We treated them conservatively. 3 days later, I repeated the CT scan and that healed. And the last thing is I saw that fella 2 weeks ago in my office. He's at GF Strong. He's starting to walk. He's as skinny as a right, but he's alive. So good job to you guys.
Yeah, he was in hospital for like half a year. This guy practically. Yeah, he was a major save, and there was lots of major learning points on the guy. So I thought it's a great case to present. Okay, so next case. We still have time. I've just got lots of cases. We'll go until we finish. Until we run out of time. So a 50-year-old female in an MVA, stable vitals, lower abdominal pain and pelvic tenderness, and gross hematuria. So she gets a CT scan. Okay, so who haven't I picked on here? Neil. What do you think of that CT scan there? I know you only get one. You get one image. That's all you get.
She's got a big bladder that doesn't look like it's in the right spot.
Yeah, so she's got the bladder looks a little high. I can tell you this distance is just over 1 centimeter, so they're talking 7 millimeters or so. 7 millimeters to 1 centimeter is about what you're allowed. So probably an open book pelvic fracture. And there's also lots of fluid. There's also lots of fluid here, and the bladder looks intact. And there's gross hematuria. So the question is, what do you do now? Do I have any other images? Let me see. Oh no, I'm afraid to change it because it's going to give the diagnosis away. I don't think I have any other images. I'm just guessing. Can't remember. So what do you think we should do now? What's the next? Is there any other tests that we need to do on this patient? Gross hematuria, intact-looking bladder. I'll just say the kidneys are normal.
Joe, has he peed at all, or put any urine, or she put any urine out at all? Or?
Not yet, no. Well, yeah, she peed. She peed without a Foley, and it was grossly bloody. Yeah.
And there's no Foley in place.
No, no. So the question is, what now? So the thing is, what now is well, basically you should do a cystogram. Is what it is, because it's important to look at this CT scan. CT scans miss ruptured bladders. Like that's a really, really important point. Is that if you're relying on your CT scan by itself to pick up a bladder rupture, you're going to miss it. And there's two ways you can pick it up. You have to do the cystogram. You can do a cystogram in the emerge, and the way you do that is you put about 300 to 500, about 400 cc's of contrast dye into the bladder. And if you're in the emerge, you have to take a whole bunch of shots. You take an AP and you take 2 obliques, and it's important you have to take you empty the bladder and then you take more shots. So that's in the emerge. But just as good as if you when you're over there is if you talk to the radiologist. And this is just another case where you probably should talk to the radiologist. You see this over there, you're over there with a patient, you see this, you say, can we do a CT cystogram? You know, there's a pelvic fracture and there's gross hematuria, I'm worried about a ruptured bladder, can we do a CT cystogram? And it's important you talk to them about the technique, because I've talked to different radiologists and they actually don't know some of them. Some of them just think you should do it, just clamp the Foley, just like what Brian was saying. But they don't. What you have to do is you have to have about 450 cc's of fluid into the bladder. So the bladder has to be distended, and then you scan the bladder, and then you'll pick it up. And it's the CT cystogram, if done properly, is the same as doing it in the emerge with all those obliques and stuff. But I would argue that CT cystogram is better, just because it's just a one-shot deal versus versus all those obliques and having to do all those images. It's just a bit of a hassle over the department. So consider the CT cystogram. So
do you have to rescan them after unclamping them?
No, that's the important point with CT. You don't have to CT scan them. So you don't have to do a post-void CT. It's good enough. Unlike the plain films where you do have to do a post-void, because you'll pick up some of the stuff that's leaked out. So that's an important point, is the indications to do cystograms. I personally don't think I've been doing enough cystograms, but I think it's important to think about cystograms. So there's 2 different types of bladder ruptures. This, obviously Brian knows what this is, but who haven't I picked on? Brian Oldring. Dr. Oldring, what do you think? Do you know what type of bladder rupture this is here?
Well, I guess you're talking about intraperitoneal versus retroperitoneal.
Right.
This looks like it's diffusing the retroperitoneal.
Yes, exactly. So this is the classic, this is a retroperitoneal. So the statistics are about 75%, or I think it's approximately like that, are retroperitoneal. And those are usually associated with pelvic fractures, like almost all of them. And then the other ones are the intraperitoneal ones, and those are typically the drunk guy who's got a full bladder who gets in a car accident and surprisingly will go home, and it'll leak into his belly and present a day or 2 later with kind of peritonitis with urine all over his belly. So that they're often missed. But this is classic retroperitoneal. So it sort of leaks out in a retroperitoneal area. There's different types. There's simple, there's complex. And it's, what is it called? The space of Retzius or something like that. I don't even know what that space is. It's some bladder space. Brian, do you have any comments about retroperitoneal ruptures?
Yeah, it's an interesting thing. I don't know why the contrast reflux up into the ureters in this case. It's really interesting. I've never seen that before. But then.
Oh, I think this is because this just happened after the CT scan.
It's coming down.
This is post CT. So it was missed on CT, and the cystogram was done in the emerge.
Oh, I see.
That's why.
Oh. Second thing is that for the most part, extraperitoneal ruptures that are smaller than 2 centimeters and not associated with bony spicules, concomitant or other pelvic surgery, terrible gross hematuria. Clots, you can treat these conservatively, but not in this case. So when a pie-in-the-sky bladder like this lady has, needs to be operated on, and the urethra needs to be not necessarily sutured back down to the perineum, but at least needs to be aligned with the urethra.
So this, yes?
To do that, you put a Foley in.
Yeah, that's right. I don't see the Foley, but it is there. I think you can barely see it. Right there. There. So this would be an example of an intraperitoneal rupture. And the classic finding there is you can see the loops of bowel. The contrast comes up and it kind of highlights the loops of bowel. Like you see multiple coils with the air inside the bowel, and the contrast that's in the urine up into the abdomen. It kind of starts more concentrated in the pelvis and gets more and more dilute as it goes up. And it typically occurs up in the dome of the bladder. So blunt bladder trauma. So 10% of pelvic fractures have bladder rupture. So that's high, and we see a lot of pelvic fractures. So you just think about it. Think if you have a pelvic fracture, especially if it's a pelvic fracture involving the pubic bones, especially if it's the anterior, the superior pubic ramus, especially if it's that, think about bladder rupture, retroperitoneal bladder rupture. Most have gross hematuria, but not all, but most do. So think about it. If you see gross hematuria, think about getting a cystogram. And 75% are extraperitoneal. Pete?
So Joel, after that, when seeing that CT scan of the high-riding bladder, I know it's a female, but do you ever consider doing urethograms in females? Like, would you consider doing
Brian,
this?
what's your call? I've never seen a urethral tear in a female before.
Yeah, well, that's obviously what happened to this lady. Her urethra is completely torn off. It's really tough to do urethograms in females. That catheter, you can't even, I mean, it's only 4 centimeters long, so where are you going to put that catheter?
So then is there a problem with putting a Foley in this female?
Well, you won't get it fully in this
Well,
lady.
but there is.
They got it in.
They got it in the ladder?
Yeah.
Oh, they're really lucky. Well, I mean, you know what? That's great if they got it in. That's fantastic. But certainly, that's very rare to get that in. Most of the time, these people need surgery. What we do is we open up their extraperitoneal space. We open up the bladder, put a catheter down into the bladder, and usually that snakes its way out the urethra. You tie another catheter to it and pull it up into the bladder and blow up the balloon and close the bladder.
So if you see this CT scan, are we going to do any harm by trying to put a Foley catheter?
No, most urologists nowadays, no matter what the urethral injury is, one gentle attempt at putting a catheter in is not going to make the situation worse. If it doesn't go, the patient goes to the OR. If it goes in, fantastic.
Okay.
Great.
Just to clarify that, when you say one gentle attempt, is that by us or by you?
You guys are gentle.
Well, it's obviously, yes, it's by the nurse.
You know,
Depends what time of day it is.
I'd probably check with the urologist on call. I don't mind if you guys try it. In fact, Eden called me about 2 months ago and said that there's this urethral injury, and took a look at it on PACS. I was in my office and I said, just give it a try. You'd probably be able to get it in, and you got it in, great. But for me, my point of view is that if you guys are just as good as most of us at putting catheters. So if you guys can try, if you guys can't get it in, I'm looking for the OR anyways. If you guys can get it in, fantastic.
How do you, if you can't get it in most of the time, how do you get a system?
Yeah, that's the problem. So what you'll do is you'll try to get it in. You'll go into somewhere and you don't know where, and you shoot a cystogram. You won't see an outline of the bladder. All you'll see is that flame, okay? And you'll know that it's not in, and you'll know that it's in the extraperitoneal space somewhere. You should. Was that catheter actually in? Because I didn't see the outline of the bladder.
Yeah, it was in.
It was in?
Yeah, it was in.
So sometimes your colleagues won't come in and they tell us to put in suprapubic catheter, but very few of us have actually done it. I mean, I've never put in a suprapubic catheter because I've never needed to. So I don't think now is the time for maybe start doing that.
Well, especially in this case, if, first of all, standards change now. It used to be that you throw in a suprapubic catheter and you leave the patient, you deal with the complications later. But that's what you do if you're in Timbuktu. In a major trauma center, the urologist should come in and realign that urethra. Not necessarily have to re-anastomose it. This also is a difficult suprapubic catheter because that bladder is high in the sky. It's not where it's supposed to be. So if you want to put in a suprapubic catheter to temporize the situation, it should be done under ultrasound guidance.
Yeah, I just think how many have you put in suprapubic catheters in the last 10 years?
Oh, probably 20.
20.
Yeah, I've put in quite a few.
How about you guys? Anybody else put in that many? No. No, I mean, so that's the other thing with, so I think that's something to communicate maybe with the urologist.
Yeah, I think it's really, that's not acceptable anywhere in a major trauma center, is to throw a suprapubic catheter in and leave it. In these kind of cases, you should realign the urethra operatively.
Great comments.
Thank you.
So different bladder injuries, there's contusion, which means basically the cystogram is normal. There's interstitial rupture, so you can get dye leaking in the wall of the bladder. There's extraperitoneal rupture, there's intraperitoneal rupture, and then there's a rare combined extra and intraperitoneal rupture. That's more common with, say, penetrating trauma, but it can happen with blunt trauma as well. So here's some key comments on extraperitoneal bladder rupture. 90% with pelvic fractures, especially if it's the anterior pubic ramus. There's simple versus complex type. The simple types can usually just be treated with just Foley drainage for 2 weeks. Tears in the lower bladder posteriorly usually, and then you get the flame-shaped extravasation with a teardrop-shaped bladder. The intraperitoneal bladder rupture diagnosis is often delayed, usually with the MVA and a full bladder. It's usually in the dome where the tear is. Most of them have anuria because the urine's not coming out, but some can still pee a little bit. And they can present with peritonitis if it's delayed. And if it's delayed, they can get hyperkalemia, acidosis, and uremia because the urine's just not getting out. So it's like renal failure, essentially. Even though it's not really renal failure, it's sort of absorptive renal failure. If a child ruptures the bladder, it's more likely to be intraperitoneal because the bladder is much higher. There's much less bladder involved retroperitoneally. So who needs a cystogram in blunt trauma patients? So fluid near the bladder on the CT plus hematuria, that would be one kind of group. Probably most patients with gross hematuria need a cystogram. Many patients with pelvic fractures just keep a high index of suspicion, especially if there's an anterior pubic arch fracture. Some places do cystograms on all pelvic fractures. We haven't been doing that, but some places do a cystogram like 100% of pelvic fractures, so just keep that in mind. Some places do that. And then if you see intraperitoneal fluid, which is hypotense, especially if there's anuria, think of it as well. So we talked about this already, about CT cystography versus retrograde cystography. They're both the same, pretty much. I think CT is probably better just because it's more convenient. So, so my conclusion is gross hematuria equals a CT cystogram. We should consider doing that. So how to do the retrograde cystography? I think
that's still a retrograde CT cystogram, not a has to be Foley and.
So the CT cystogram, the way you do it is just you put a Foley in. You have to put 400 cc's in the bladder, and then you take a CT scan with the bladder fully distended, not just some delayed views or something like that. Delayed views aren't good enough. So retrograde. This is basically the technique for doing retrograde cystography, and they talk about taking some images just with a little bit of urine or a little bit of contrast in the bladder, like 100 cc's, and then put the full 100 cc's in, take another image, and then doing post drainage films as well. All right, next case. I think, do we have time for one more case? We have 5 more minutes? Or? All right. So this 30-year-old man was crushed by a car against the wall. He's got a negative fast, he's got an unstable pelvis, and he's got blood at the urethral meatus. So He's got many things. He's got the open book pelvic fracture, he's got blood at urethral meatus, and you can see he's got a huge scrotal hematoma as well. So what does he need?
Urologist.
He needs a urologist, okay. But he probably needs he for sure is going to need a urethrogram, right? You guys buy that? So this is his,
How did you put the binder on to keep his genitals exposed like that? What a hole.
Cut a hole.
You just
Cut
cut
off.
it, you actually cut that
we
away.
cut it away.
That's why we like the binders, the blankets, because we can cut the sheets right away.
Okay, cool.
So this is it here. And whoopsie, so what now? And there it is. There's the urethrogram. So the urethrogram is positive. So then we called Ryan or somebody. I think it was Warner who was involved in this case.
No, it was me.
Was it you?
Yeah.
Okay. Yeah. You remember this guy?
I remember.
Yeah. He did well. So there's another urethral injury there as well. This is a guy who was shot with a shotgun penis. So so urethral injuries. I think this is probably we'll stop here. I've got a bunch of other cases, but we can probably stop. So there's different types of urethral injuries. There's type 1, 2, 3, 4, and 5. So type 1, the puboprostatic ligaments ruptured, so the prostate moves superiorly. So this is kind of just up underneath the bladder, but the urethra is intact still. It's just really stretched out, and that's the type you can just probably stick a Foley up, and it'll go right into the bladder. So the urethra is tethered but not ruptured. Type 2, the urethra is actually torn, and but it's above the urogenital diaphragm, so it's not through so the contrast doesn't leak below the urogenital diaphragm. Type 3, it's torn, and the urogenital diaphragm is ruptured, so there's contrast above and below the diaphragm. Type 4 involves an area in the bladder neck, and type 5 is the anterior urethral tear, like that gunshot wound of the penis. So those are the sort of the 5 types. Type 5 would also be the type you'd get with a fractured penis as well. You can get, I think 30% of fractured penises can get urethral tears. Any comments on that, Brian? That's pretty much the classification scheme. So how to do a urethrogram? I personally use a Foley. I think it's better. Some people use one of those gastric syringes with the tapered tip, but I like the Foley because the Foley's good. And I've seen if it's a Foley, it's nice and clean and tidy, and I put the Foley in, not a very big one, maybe 12 or 14. You stick it in, and you have to put it in about 5 or 10 centimeters, but not too far. And then you blow up the balloon, and just enough so the patient has a little bit of pain, but not too much pain. And then what you do is you start injecting the contrast, and you inject a little bit and take an image, inject a bit more and take an image, and then you can get a good image that way. And it's not going to leak all over the bed. And then you can take the Foley out when it's positive, or talk to Dr. Yang, and he'll say put the Foley in or whatever. So that's basically how to do it.
Are those right in Trauma Bay, or do you forgot a radiology?
Trauma Bay. Trauma Bay.
Just go back a couple of images to show that picture.
That one?
No, back there. And see how he's set it off to the side so that if there is any leakage, it doesn't go down back in behind it.
Joe's an expert at these,
Catheters
apparently.
coming in off to the side and up into the penile area.
It's useful to know how to do these things, right? Because it doesn't happen that often. But if you ask the radiologist to do it, it's just not fair on them. Some of them have never done it. Some of them have. Many haven't.
So Barry, are you saying to pull the penis off to the side to do it? Is that?
No, you just put the catheter up to the side
Off
so
the
that it's
side.
not just straight on, but you pull it out to the side so that if you're injecting it, it happens.
To slip.
Leak a little bit, then it's not going to end up right underneath.
Oh, I see.
So the urology Royal College protocol for this is take the patient 30 degrees up on his side, bolsters in place, bottom leg bent, top leg straight, so the penis is sitting on the thigh, and you do exactly what Joe said. So 30 degrees up.
But not in trauma patients, with back injuries and pelvic smashes and.
So here are the indications for urethograms, like scrotal hematoma, blood, we know that, high riding prostate, Personally, I do it in all unstable pelvic fractures with our open book. And then obviously anything, patient can't urinate, can't pass urine, you're worried about it, you do urethrogram, penetrating penile trauma, penile fractures. It's only 30% with penile fractures, so it's more like penile fractures that can't pee, or penile fractures that have blood at the urethral meatus. You probably do a urethrogram, and usually not in females, although sometimes maybe. I've never done it in a female. I don't know how I do it. All right, well, I've got more cases, but we'll probably stop there. It's 8:30 now.
Thanks, Joe. That was really good. There's no radiologists here, I don't think. But coming out of this, one of the practical things, I guess, is if you're saying that there's different techniques in radiology for the cystograms, it might be nice for the trauma program to communicate with the radiologists about, A, we're going to do more of these, and B, here's what we'd like done. And it sounds like there's a consensus from you and Brian. So maybe
Yeah, it's worthwhile talking to them about that. Yeah, I think it's worthwhile. I can do that. Okay, we're done. We're done. Yay.